안녕하십니까. 이좋은 치과의 손영희입니다.
Hello, I'm Son Young-hee from E. Joon Dental Clinic. Today's topic is socket preservation. So, socket preservation is something that is commonly done these days. I believe it's mid-2000 when I first tried socket preservation, and at that time not many were doing it, but it has now become quite a common surgery. So, socket preservation, that surgery itself, has existed for a long time, but it didn't really attract much attention. So, before mid-20th century, there was not much interest, but with the advancement of implantology, it has become one of hot topics. So, socket preservation rationale is to create sufficient bone volume for ideal implant placement, and this is to retain soft tissue volume, and this is to minimize bone resorption and soft tissue contraction. And it could also reduce treatment time and also decrease patient morbidity and the cost patient needs to pay. And with this socket preservation, you could also have more aesthetic results. And by doing socket preservation, the most important thing that you can obtain, in my opinion, is that you can preserve gingival architecture. I think preservation of gingival architecture is the most important goal of doing socket preservation. Now, there are different ways of doing socket preservation, and it can be roughly classified by membrane. First, you could use resorbable or non-resorbable membrane, and second classification could be by graft material that you could use. Now, you could do allograft or do xenografting, or you could also use synthetic bone graft substitutes. And you could use like collagen membranes, and you could do with or without implant. Do immediate implant placement or wait to do later implant placement. So depending on the cases and situation, different approaches can be selected. So let's look one by one. So first is using collagen membrane in doing your socket preservation. This is the most popular approach. I believe in most cases you use collagen membrane these days to do socket preservation. For this patient, number 26, as you can see, the buccal bone has been all resorbed, and you can see periapical bone losses here. So buccal side look like this, and for this case, after extracting tooth, when you open flap the buccal bone, there is a dehiscence defect. So here, after extraction, you could wait for natural healing, but that will result in hefty tissue loss on the buccal side. So for this patient like this, you do bone grafting, and as a bone graft material, I don't know why, but when you use collagen membrane, I think you often opt for xenograft. I mean, there's no theological rationale for doing xenograft. My experience has been that so far. And when you use non-resorbable membrane, I think often you go with allograft. And like this, you cover the collagen membrane, and like this, you suture it up and finish. So after 1 week post-surgery, you see the gingival has not really healed properly. So for this patient, there are two types of collagen membrane, and natural collagen membrane could be used, or like this case, cross-link collagen, synthetic collagen could be used. And depending on which collagen you use, there could be different tissue reaction. Now, I didn't write this up here because it might be only my personal opinion, which is solely based on my experience. So you cannot really say whether this is right or wrong. But in my opinion, when you do socket preservation, like orally there's exposure and you have to retain the membrane, then natural collagen seems to deliver more favorable results, a more stable tissue reaction. That's my personal opinion. But cross-link collagen could, of course, can be used, and you will see here why. This is 3 weeks later and 16 weeks later, and as you can see, healing-wise, regardless of the membrane that you use, because of the characteristics of the collagens, a very good healing pattern can be obtained. So this is 16 weeks after surgery, and using guide at that time through flapless surgery, implant was placed, and even prosthesis was then delivered. So for this patient, this is a series of the patient CT view before surgery, then after socket preservation, before implant placement, after implant placement, after prosthesis was delivered. So the grafted volume as is and gingival architecture as is has been quite well retained. So gingival architecture couldn't be well retained because looking at the CT, labial bone has very minimal remodeling, and based on that, gingival's architecture, I believe, can be maintained quite well. Now, we looked at using collagen membrane in doing socket preservation, which is the most popular way. Second option could be using non-resorbable membrane. So let's look at that with actual case. So for this patient, number 37, in the periapical region, you see problems on the CT also. It's very close to canal, so we didn't want to risk it. So after extraction, after socket preservation, after bone is remodeled, we decided to do bone implant placement. So after extraction, tooth is extracted. For this patient, we did allograft and PTFE, dense PTFE membrane was used. You cannot use expanded PTFE membrane. Of course, that type of membrane is no longer sold on the market. But so most PTFE membrane that you will now buy will be dense PTFE membrane. So again, dense PTFE membrane was used and sutured. So this is post-op X-ray, and like this, after surgery, it was finished. So then after 1 week, so dense PTFE membrane, you can use like this exposed because this membrane's pore size is less than 0.3 micron, and in the mouth, the bacteria that is there, the smallest diameter of bacteria is bigger than 0.3. So the bacteria cannot filter through the membrane. But of course, when you deliver it to the mouth, the exposed area should not be held with pincet. So you just have to be careful of that. And secondly, this PTFE membrane-based socket preservation is like this. After 4 weeks, the membrane needs to be removed. And with the membrane being removed, you might be worried the bone might be exposed. But if you actually see it after 4 weeks, And if you remove it with the pincet and look at the underneath, as you can see here, now we look at pseudoperiosteum, 1 millimeters of thickness, fibro tissue layer exists, and it doesn't touch the graft material itself. So after 4 months, like this, it's healed very well. Of course, collagen membrane and PTFE membrane, in both cases, healing patterns will be different depending on which membrane. I'll talk about that later. Bone consolidation was good and initial stability was good, so it's very well regenerated socket. Of course, because of allograft, it might have had better bone quality. So after placing implant, prosthesis was also delivered. Now, in the past, I used this approach quite common, but nowadays, I opt for more collagen-based socket preservation. Now, collagen membrane and PTFE membrane would have different gingiva healing pattern. Now, as I said, in case of collagen membrane-based socket preservation and PTFE membrane-based socket preservation, the healing pattern is different. Let me explain about this. Now, collagen membrane with the collagen membrane, even using other graft material and not matrix, if you use collagen membrane, then the collagen membrane itself, tissue friendliness would the gingiva side closing up together to close up the open space. And for non-resorbable membrane, the PTFE membrane, in that type of socket preservation, as I show you, at 4 weeks after, if you remove membrane, then about 1 millimeter pseudoperiosteum layer exists. And the pseudoperiosteum layer, the gingival tissue around it, it fuses up, and the opening area is keratinized, and it closes the opening. So it has a bit different healing pattern, but the result is similar. And the difference between the two is like this. In case of soft tissue architecture, two are well maintained, but when it comes to underlying soft tissue thickness, collagen is thicker. And for the regenerated bone quality, you could say like this PTFE membrane is a bit better. And as for we have to then, of course, deliver implant. So you wait about 4 months before delivering the implant. So that latent period, whether that is sufficient, it seems that for a collagen membrane, for socket preservation, waiting longer than 4 months might be a safer option. That is my experience. But when you use PTFE membrane, then 4 months is sufficient wait time. So there are pros and cons depending on which membrane you use. But still, in terms of mastication or adverse event possibility, collagen membrane might deliver, it seems to deliver better results. Now, secondly, up to now, we didn't place implant, but did socket preservation first. But with implant, doing simultaneously socket preservation is also possible. We used this as open membrane technique in the past. Now, on number 36, there's a purification involvement, so tooth need to be extracted. And after the tooth was removed, we drilled and the placed implant, and initial stability, like you see it's very not stable. So placing implant, we submerged it, and you did allograft, and PTFE membrane was covered and sutured. And that could be an approach. So you could preserve socket with implant, and you don't have to revisit again. But you actually have to revisit because you need second surgery. So we placed implant on the CT. It looks like this. And when you preserve sockets, what I would like to recommend is when you do grafting, do a bit more excessively. So it's much better to do excessive grafting. And after 4 weeks, this is how it looked. And after removing membrane, you can see it's not keratinized yet. Pseudoperiosteal layer exists. So like this. In case of PTFE membrane, this is the outer surface and this is the inner surface. On the outer surface side, it's exposed area and it's contaminated, but inner surface, there's no contamination at all. So it covers very well. So if you retain it, maintain it after 4 months, then it's healed and keratinized, and rich width is also maintained, and gingival architecture is well preserved. So after you open it up for second surgery and you finish, so after second surgery, CT image, and after 7 months, like this, you deliver prosthesis, and then you take CT. So this was my common approach in the past, but nowadays, as I told you, I do socket precision first and then do implant placement later. Of course, but does not mean this is not the way. This is also another option you can do. This is 6 years follow-up images. So the buccal bones and palatal bones are with very minimal remodeling. It's well retained. So you can also socket preservation and do implant placement simultaneously. Next is based on graft material. I used, up to now, like xenografting or allografting. But nowadays, collagen graft has become very hot. In Korea, there are different types of collagen graft materials on the market. And I will not talk more specific here, but in my training material I do. But there are different characteristics of this collagen graft material. So what would be best way for implant placement? I will just use a very simple case. So for collagen graft material, like you see, there is a aggregation property. 10% of collagen and others is graft material. So it's a collagen type 1 dominant collagen. So socket is preserved like this. And when you put it in, it doesn't scatter. It retains very well in the form. And this is AOS collagen. It's that type of graft material, and collagen membrane was used to cover it up and then sutured. Now, when you suture, for socket preservation, what you need to be careful is that there could be different types of sutures. Cross-matrix suture could be used for, or you could do crisscross or hitmix suturing, and there are different types of suturing. And depending on suturing, different prognosis, no. So only wound and membrane. If you can stabilize with suture, what type of suture is not important. What is more important is you should not pull it too tight. If pulling it too tight could result in bleeding ischemia of gingiva to result in more retractions. So don't pull too tight is more important. And when you preserve a socket with usage of collagen materials, it has become very simple surgery, and it delivers very consistent results, irregardless of the surgery technique. That's my judgment. In other words, even I can strongly recommend you doing this. So this is after surgery panorama image, and 1 week and 16 weeks later follow up. So like collagen graft material is used for socket preservation, then at least 16 weeks later, I place implant placement, because if you do earlier than 16 weeks, there could be no initial stability. So I recommend waiting for at least 16 weeks. And depending on material, 16 weeks sometimes is not sufficient even. So implant placed after 16 weeks, and this is CT after 12 weeks. And like this, bone consolidation has progressed quite a bit, and used guide surgery and delivered implant flapless, and initial stability was secured, and implant was placed, and healing abutment was delivered and finished up. At 16 weeks after implant was placed, panorama and CT images. So, of course, at 16 weeks, it's mostly woven bones, and this is inevitable result. But after this, the most important thing is how the healing pattern would look like. So for this patient, we waited 3 months more, and implant and prosthesis were delivered at 28 weeks, like this. And at 28 weeks, panorama and CT images. Even now, even just after 28 weeks, bone consolidation has progressed a lot, and you can see full architecture is more or less available. So like this, this most common way I use: extraction, socket preservation, then implant after 16 weeks, and latent period for 3 months, and after 3 months, implant and prosthesis delivery. So it's a protocol that takes about 7 months is what I most often use these days. And with this protocol, very safely, you can deliver implant and also minimize patient discomfort. So for this patient, this is follow-up after 25 months, 2 years, 1 month later. This is the CT image. So before surgery, then socket preservation, and then after implant was delivered, then 25 months later, bone consolidation can be seen. All was taken with the same CT device, so there's not much of a variance. So this is the result you can obtain. So let me give summary of this topic. Now, socket preservation is very simple surgery. You extract, remove the residual tissue, do grafting, and cover membrane, and you suture it up. So it's a simple surgery, but the result is very safe, and it's consistently very successful. So by doing socket preservation, the main thing you can obtain is you can preserve the soft tissue architecture and regenerate the hard tissue underneath, in my opinion. And there could be different types of graft materials and membrane materials that you could use for socket preservations. And with this graft material and membrane, you have to, of course, choose the proper ones in terms of material and membrane for successful results. One thing I really want to tell you is that when you do socket preservation after doing grafting, always use membrane. Without membrane, if you do just socket preservation, then of course soft tissue architecture I also believe can be preserved, but the bone quality that's going to be regenerated, my experience tells the quality can differ. So for best result, my advice is use membrane. So today we looked at socket preservation. Now, socket preservation is, preserving the soft tissue architecture and regenerate the bone. It's a very safe, and you can have successful result. But you need to have good understanding of the patient's situation and be good in opting for the right materials. And through that, when you do implant surgery for the patient can have less discomfort. Thank you for your attention. Thank you.